We're starting up again with our paper presentations, and this session has the very succinct title, Health. Our first paper is titled, See My Work, Sustaining a Data Reporting Practice by Mental Health Clinicians in Liberia. The speaker for this paper, Elena Zegura, at the last minute was not able to make it to the conference, so the paper is going to be presented by her colleague, Mike Best. We're not going to take questions since Mike is not really equipped to answer questions about this project, which is not his own. So we'll after he presents, we'll roll on to the next paper.
Okay, thank you very much. And on behalf of Ellen, I bring greetings. She unfortunately just got tied up with a family issue, not an emergency of any sort, but just kind of a thing that didn't allow her to come, and I know many of us are very sad that she's not able to participate. I will do my darndest to give a reasonable presentation and the quality that it deserves, in particular given that I think this is really interesting and exciting work that she's been doing over 5 years in Liberia. So the basic outline of this presentation is to give some context as to the project, which is in Liberia and focused on mental health, to then discuss data reporting technology and training for this mental health project, the research questions and findings as they relate to two of the most salient issues. One is this sustainability of clinician reporting in this mental health technology intervention, and then sustaining the actual software artifact itself, and end with some discussion. So Liberia is a small West African country that suffered through 12 plus years of devastating civil war, beginning in about 1989 and ending in 2003 with a comprehensive peace accord drafted in Accra, Ghana. Nearly all of the infrastructure was destroyed during the civil war, including the entire fixed line network and essentially the entire energy network infrastructure. About a third of the population, nearly 1 million people, were displaced during the conflict. About 300,000 people were killed. It was an absolutely devastating period of hot fighting and civil war. The country then, after the Comprehensive Peace Accord, has been enjoying a decade or so of redevelopment, growth, disarmament, and reintegration, but tragically, most recently is known for an Ebola breakout that occurred at the ends of 2014 into 2015. Only, I think, 2 weeks ago, if I'm recalling correctly, Liberia was proclaimed to be Ebola-free, and they're back again to a period, we hope, of economic, social, and political development. The Carter Center is a large US-based, Atlanta-based NGO that was founded by former US President Jimmy Carter and his wife, Rosalynn Carter, and it focuses on a number of areas, including a very large democracy program that in particular is well known for their international election observation activities, and a large program in health, for instance, being well known for eradication of guinea worm in many, many countries, especially in Africa, and programs in mental health. And the mental health programs were founded particularly due to the energies and interests of Mrs. Carter, who has been a mental health advocate for many decades. The Carter Center has partnered with Liberia on a 5-year mental health program, which started in 2010. It's a complement to a previously existing democracy program that focused on rule of law and on judicial reform issues. So the mental health program was a complement to a otherwise quite rigorous intervention and series of activities of the Carter Center in Liberia that's existed ever since the Comprehensive Peace Accord was signed. The mental health program in Liberia in many ways is a first for the developing world. We see very little attention in Africa to mental health. We can discuss why that could be, but one reason certainly is that the overall health industry there, health sector, is quite challenged. And in Liberia, the health sector is very, very oriented towards many physical health challenges. The mental health program, in the case of Liberia, being very minimal, and at least we narratively understood that during the civil conflict, there was only a single MD-trained mental health practitioner in the country, one such mental health doctor, a psychiatrist. So a very small mental health kind of context. 3 elements of this program in Liberia, the Carter Center program focused on 3 elements, I should say. One is national policy. The second is capacity building of the clinicians, and clinicians here can be anything from nurses to doctors to other trained health providers, and community-based support around mental health issues. Georgia Tech has partnered with the Carter Center on actually quite a range of projects in Liberia and across other areas where the Carter Center is engaged. In the Liberian context, though, the partnership with the mental health program has had 4 main elements of support. Those are consulting on low-cost laptops. And so every clinician who passes through the mental health training program that the Carter Center has developed for them is given during their graduation a low-cost laptop running Windows. They're also given a few other goodies, and you can see in this image, that's Ellen giving a graduation package to one of the clinicians that had passed through the Carter Center training program, and you can see there's a surge protector as one of the gifts. This, of course, is maybe not what most most clinicians expect after coming through a mental health training program, to be gifted a surge protector, but if you know the Liberian context, it's a very sought-after object because the power system is notorious for spikes and unclean power and has a tendency to zap anything that's connected into the network. The second area of Georgia Tech's role in support of the Carter Center program has been the development of a clinician reporting software tool called PEF for the Patient Encounter Form. It's the tool that I'll be describing most in this talk. The third area is training the clinicians in the use of this software, and this is done at about 2 times per year. The training includes trainings for new cohorts of health clinicians who are coming to the first time to learn about the PEF system, as well as in-service training for folks who have experience already, who've gone to former trainings for the PEF system, but want to come and retool themselves on the PEF software. And then some data analysis and visualization. So what about this PEF, Patient Encounter Form software system? The software was developed at Georgia Tech and developed through the use of students who are part of the Compute for Good program, which is a senior undergraduate and master's capstone design seminar series, project-based and client-focused. And so students over the course of about 5 years have been working under this Compute for Good senior design project course to develop the patient encounter form system. The system is used by clinicians to report data on each patient encounter, including information like the patient demographics, diagnostics, diagnosis, treatment plan, and discharge. The system preserves the patient confidentiality, yet allows linking of repeat visits via a generated patient ID, and this is done by hashtagging or hashing the first name, last name, date of birth, and gender of the patient That, if the names are entered in consistently and the date of birth is entered in consistently, will create a unique patient ID that then can be reapplied every time the patient returns, and this allows anonymous tracking of the patients in the data set. So the data set anonymizes the patient. Of course, the clinician patient encounter is not anonymous, and that's not a goal of the system anyway. And it supports offline data entry followed by upload to the crowd, and this, of course, in a context such as Liberia, where the internet is very dodgy, often not present at all, and if it is present, can come on and off throughout the day, especially in the rainy season, which can be which can cause long periods of time where the internet is not available. A system that allows for offline data entry and then stores and forwards that data to the cloud when the internet is available is a really important feature for a software system in this kind of setting. So the training of the clinicians for using the PEF system, clinicians are trained in 6-month cohorts, so the training is every 6 months. Initial PEF and computer training was a half-day session, so the training would include both using the particular application for entering a patient encounter data, but also just basic literacy training on the laptop that was given to them after the training was completed. The follow-up training was a 1-day in-service every 6 months with travel and meals provided, travel to the capital city of Monrovia. Clinicians from all prior cohorts were invited to all of the in-services. So once you went to the initial training, then every 6 months you'll get an invitation to an in-service training for the 1-day kind of tuition on PEF system usage that you've already gone through the initial training. So there's many steps to successfully upload a PEF after you've seen a mental health patient. The first is that the clinician would take notes, would then have a working and powered laptop, would then fill out and save the PEF correctly, get internet access, and successfully upload. And so the point of showing this workflow is that there are many, many points of potential failure along this workflow, and any point of failure would mean that the encounter form is not successfully uploaded to the cloud and therefore does not successfully get integrated into the data set for analysis. In terms of this paper, the two main research questions is what has enabled sustained participation by clinicians despite the many challenges in using this kind of system. Sustained meaning roughly 5 years of clinicians using the encounter form and uploading 4,000 roughly PEF forms, of which 3,000 were deemed to be high quality. And what has enabled sustaining training and software development by Georgia Tech for over more than 4 years. And I should say this report, the paper in the proceedings here, tries to answer the first question in particular through survey and interview data. And let me, I think, now drill down a little bit more. So there were two components to answering this sustainability question. One was a survey, which is a formal paper survey, mostly with Likert scale style questions. And the second was interviews, which were semi-structured, in-person interviews and qualitative assessments. For the survey, 53 clinicians, all of whom were attending an in-service in July 2014, and that is 44% of the entire collection of trained clinicians across all cohorts, so nearly half of the entire set of trained clinicians, were given the survey and completed the survey. The survey was not anonymous, and the idea was that the survey would be used to then select people for the in-person semi-structured interview, though in the end that did not, I don't think, occur. There were 5 sections to the survey. the first on prior education and computer experience, then on clinical practice, their clinical practice setting, then on their training and learning to use the PEF, their barriers and motivation to participate in the PEF and workflow. Sections on barriers and motivation. So based upon the survey work and then on the interviews as well, clinicians self-identified as light, medium, or heavy PEF. Well, first of all, sorry, let me back up. Clinicians self-identified as either light, medium, or heavy PEF users, and then the survey branched based upon this identification. And by light users, that means that they said that that most of the time they were not able to go through the entire PEF workflow. That at some point in that workflow, something broke down and therefore they were never able to completely submit a form. It could be that the breakdown was that they never tried to submit the form. It could be that they entered everything and they never had internet access and therefore they never submitted the form. But something along that workflow inhibited their ability to submit the form for aggregation into the cloud-based data set. And so those were called light users, and nearly half of the users were considered light users by this definition. Heavy users were people who a majority of time they tried to sort of work through that workflow. In other words, encountered a mental health patient, made it all the way to submission, were heavy users, 14%, and then 38% were medium users. Those were folks who were more like the 15 to 50% of the time they tried to get through the workflow, they made it. Heavy users may be underrepresented since they have the least need for in-service training. The interviews were 12 interviews, each of about 30 minutes, selected for coverage across all cohorts, but most recent, those folks who didn't have a lot of experience with the system were not interviewed. Selected for gender balance and for some geographic coverage across the counties. Clinicians interviewed attended the in-service or were available in the capital city. One of the interviews was conducted by Ellen and the other by Elena, who was the research assistant, who was a research assistant not involved. And so the findings, motivations to participate. External importance and visibility really matters for these people's motivation for participation. In the medium to heavy users, we heard quotations during the interviews that it was important for from the surveys, it was important for the Carter Center mental health program was rated as very important by 87% of the respondents, and 94% of the respondents said that it was important for mental health in Liberia to have data collected. So they were very motivated by external sense of visibility and importance. And then 77% rated as very important that they were proud of their practice and wanted to share information about it. So their own personal pride in the work also was very motivational. In one of the interviews, one of the respondents said that one of the motivating things is that it helps we, the clinicians, to let the Carter Center know that we are working, we are in the field, we are implementing what they have taught us. Carrots were much more dominant than sticks. In other words, positive reasons to participate were much more dominant than negative reasons. For medium to heavy users, 83% of users rated as not important, that they were afraid that EDGE might be taken away. And the EDGE is one of those GPRS modem dongles that you can put in to a USB on your laptop, and that was how they mostly were connected to the internet. 48% rated very important and 37 as not important, that they don't want to disappoint the program director. In other words, it was bifurcated, and it was bifurcated by 41 and 44% very important to not important, that they don't want to disappoint the technology person. So there we don't see consistency across the survey participants. In terms of barriers to participation, technology was the main barrier. Internet non-availability, internet being intermittent, edge devices not being reliable, and laptops inflicted with viruses. Also, a barrier was just the workload of the clinicians. Now, those were some results in terms of what enabled sustainability of the acquisition of encounter data from the trained clinicians. In terms of software development, this was built by a team of undergrad and master level students, as I mentioned, participating mostly in design capstones called Compute for Good. The first version, built in 2010, was web-based and it required an Apache server to be installed on the laptops. It had some issues also with patient ID generation. The second version, built in 2011 and refined in 2012, was a Java app-based system that was installed on the laptops. All of the maintenance of the 2012 Java-based system has been done by a graduate student named Greg while he's been a full-time employee with Google in Silicon Valley. And the this Master's of Science graduate student who had first started the development of the software when he was a student in the Compute for Good class, continued on for a master's program thesis credit, and then again continues to maintain the software to this day. And so one question that Ellen is asking is, why is he still doing this work even while he's you know, a well-paid software engineer at a major multinational? He reports that it feels good to be able to use my talents to help other people. I like that it enables me to stay in touch with Georgia Tech, which I credit for giving me the opportunity to learn and advance on the path that I follow today. It's nice to know something I helped create is continuing to serve a useful purpose, and I like maintaining it and improving it so that it can continue to serve its purpose. So back to discussion on pride. Clinicians' pride felt as individuals, as a collective, mental health clinicians, and as citizens of Liberia. And the survey highlights individual pride, while interviews call out collective and national pride. And for the sake of winding up, Ellen then goes on to link this to pride in the literature, where pride is a positive emotion connected to accomplishments that involve public evaluation of the self. And one can see that this is clearly about contributing data that can be then publicly acknowledged in aggregate data. So that then suggests that pride is a salient element to the psychological factor that enabled sustainability of this project. And I think Ellen makes an important point, which is that that actually can be seen as a broader potential success factor in ICTD projects that isn't very often brought to consideration. And in particular, since this is essentially a top-down and maybe technology-driven project, and therefore would fall into kind of a anticipated failure mode, the fact that it succeeded to sustain itself might be due to this cueing that comes through pride. And Ellen links that to the ICT project success literature. And then she ends with, I think, an apt tribute to Gaetano, and of course many people have been doing this for Mark, Gaetano, and Gary, but Gaetano was very important to Ellen in her transition from really a more traditional networking computer scientist to somebody who's now very engaged in the ICTD community. She had communicated with Gaetano about how difficult it is to enter the community. He said it's only cold when you first jump in. So Ellen ends with her thanks to Gaetano, and I end with my thanks to you all for tolerating my less than perfect presentation. And I didn't do Ellen justice, but I did my best in any case. Thank you very much.